Good afternoon or good morning, everybody, depending on where you're located. We are here for our special monthly live stream. I'm Mike Wayman, of course, joined here by my mom, Marianne Wayman, founder of NCAN. And today we're doing a live Q&A with Dr. Joseph Dillon from the University of Iowa. The way that you can attend and actually participate in this live stream and ask your questions is you can text 516-584-4576. If you text that number, we will be able to get your questions and we will ask them to Dr. Joseph Dillon. But yeah, Dr. Joseph Dillon, thank you for joining us.
Hey, you're welcome, Mike. It's good to be back with you and Marianne and Bob in the background, and anybody who's joining us on Zoom.
So, Dr. Dillon, just tell us a little bit about yourself. Some patients may not have known you, so can you just tell us about what you do at your practice?
Yeah. So I work at the University of Iowa. I'm an endocrinologist by training, as I'm a hormone doctor. Over the last 10 or 15 years, I have focused my practice pretty much entirely on neuroendocrine tumors, hormone-producing tumors, and so that's what I'm doing at the University of Iowa. Being an endocrinologist and not a medical oncologist, I work in a multi-specialty group at the University of Iowa, where we have a dedicated medical oncologist, Dr. Chandrasekaran, and a surgical oncologist, Jim Howe, and multiple other people in our group. I think that's important to have a team approach.
Absolutely. Absolutely. We're going to start off with a few questions before the questions come in from the text. So let's see. If a patient isn't is inoperable, what is the best idea of, is it chemotherapy? Is it lanreotide? Is it standard if it's a low grade?
Yeah. So that's a tough one to start off with, Marianne.
Oh, sorry.
So it really depends on the details. And first of all, I'd start off with inoperable, because I don't know how many people, and you probably know lots of people who they go to their initial oncologist and surgeon, and they say, no, this is inoperable, by which they mean, I think, we cannot cure this by surgery alone. Now, I think one of the things that's different with neuroendocrine tumor situations than with other carcinomas and other cancers is that there is a role for surgery in patients who cannot be cured by surgery. There is good literature, there's good history that people who have surgery to remove their primary tumor, to remove lymph nodes, to remove as much as possible of tumors in the liver, do better, live longer than people who don't go through that process. So and again, I would get back to the concept of a multi-expert team. Sometimes you need a multi-expert team where you have both where you have a surgical oncologist who is a neuroendocrine tumor specialist, because inoperability would be the first question there. What is, whether some operation will be beneficial to a person. Taking on after that. So let us say that despite seeing an expert surgeon, that expert surgeon says, boy, this an operation would be simply dangerous here, and I wouldn't be able to get much tumor removed. Then again, there's a lot of issues about the details. There are some There are some therapies that that shrink tumors. So certain patients with pancreas neuroendocrine tumors particularly might benefit from a chemotherapy cocktail at that stage because it has been shown to shrink tumors. Other patients, although it's not feasible to or wouldn't be particularly beneficial to operate on them, they may have some symptoms, but they have relatively small amounts of tumor. In those persons, just keeping the tumor stable is a goal, and those people would benefit from consideration of the monthly injection, lanreotide, sandostatin, one of those monthly injections. So there's a lot of meat in that question, and each person has to be really evaluated in terms of where their tumor is, how much trouble they're having with their tumors, what grade their tumors are, and gets down to the nitty-gritty of the pathology report to really tease out the answer. Every zebra is different, as I should remind you, Marion.
That's true. That's true. Yeah. And as a reminder, that's why it's very important to go and see a specialist and a multidisciplinary team. A lot of the local doctors may say you're inoperable, but going to somebody like Dr. Maluccio or Dr. Howe or Dr. Liu or Dr. Pommier all have experience. So well, a lot of doctors may say you might be inoperable. They may be able to operate. So it's really important that you do get a second opinion at some point during the thing, as well as even with regular endocrinologists or oncologists, because if a doctor is spending most of their practice, they know a little better of the up and coming treatments and things like that. What is the treatment if you're having a lot of diarrhea and the lanreotide isn't working, or the sandostatin? Do you recommend things like Zormello? Are there any other benefits of taking Zormello, or is Lomotil very positive, or Imodium? How do you tell patients to help control their diarrhea?
Sure. Again, a question with lots of things to unpackage there. The diarrhea is, as many people in the audience would know, diarrhea is a key component or a key symptom in the carcinoid syndrome. Now, the carcinoid syndrome doesn't affect a majority of people. Many people develop diarrhea after the surgery for their neuroendocrine tumor, and it may be related to their gallbladder having been taken out, or shortened bowel. Many people develop diarrhea or oily stool or gassiness after being put on lanreotide or sandostatin as a side effect of those medications. Many people have their diarrhea because they still have remaining carcinoid tumor. The reason that I point out all of those things is that each of them have a slightly different approach. So in a person who had diarrhea to begin with their carcinoid syndrome, and then perhaps had a surgery but didn't remove all of the tumor and still has carcinoid syndrome, those people, if anything, we might help by either consideration of increased dose of sandostatin, octreotide, or lanreotide, or addition of Zormello. However, in a person who say may not have had diarrhea before their tumor was removed, but then immediately after surgery has had diarrhea, well, those people, they might benefit from something that takes care of the diarrhea that occurs after removal of gallbladder or removal of part of their stomach, part of their intestine. And those would be medications like Questran, cholestyramine, Colestipol. in many people who've had the complicated and extensive surgeries that people do, they can get overgrowth of bacteria, and the best thing for them will be actually antibiotic treatments. People who have the Lomotil you mentioned, Lomotil, Imodium, those are sort of general antidiarrheals, and I certainly recommend those for people if as an add-on or something that can take care of the risk of diarrhea if they need to go out and potentially be away from easily available restrooms. So there's again a number of possibilities for the diarrhea. I certainly do use the Telotrestat as an add-on to the lanreotide. I should mention that also lanreotide and octreotide have a side effect of diarrhea, which is taken care of by pancreas enzymes. Something as simple as over-the-counter papaya extract tablets or other pancreas enzymes may be enough to take care of some of those gastrointestinal symptoms that are caused by the lanreotide or the octreotide. So, sorry, a number of aspects to that answer as well. No simple answers.
That's okay.
No problem. No problem. So we've got a bunch of questions rolling in here from the text. Once again, I do want to remind everybody that this is text in only. This is not, you cannot call in to ask these questions. This is text message only. So first off, I want to bring it back to your official plan or your treatment plans. Is there an schema or a plan, official plan, available for patients to see at University of Iowa or no?
Is there a formal way that we do the treatment? What would be called
like in a schema, yeah.
A scheme, right? So we do have a schema, which I show to every patient who comes through. We like to make sure that our patients have had a reevaluation of their pathology, because sometimes we find that what was diagnosed as one thing in one hospital, when our expert neuroendocrine tumor pathologist looks at it, he may have a different opinion, which can significantly change the treatment strategy. We like to make sure that people have the what is called a somatostatin receptor on their tumors, because that is something that is important in determining whether lanreotide or octreotide will be helpful to them, whether radioactive forms of octreotide would be helpful to them. That's the treatment we call PRRT. So we like to know that up front, either on our pathology or with a PET scan, a dotatate PET scan. So not the usual cancer PET scan, which is a glucose PET scan. So that's what we do initially, and then always on day one, my first big question that comes to mind is, would this patient benefit from surgery? And we've talked already about operability and inoperability. I think there are certain windows of opportunity for different treatments. I think a window of opportunity for surgery is early on. That's not to say that surgery may not be performed at a later stage as well. And then many of our patients end up with surgery and being on a monthly lanreotide or octreotide. But depending on the situation and depending on when we are getting to see a patient, they may have gone through surgery and had progression on lanreotide, and so we are then talking about there's a discussion about treatments such as PRRT or chemotherapy, or in patients who have most of their disease in their liver. There's another form of treatment which is called liver embolization, which is essentially clotting off blood vessels to tumors within the liver. So we have an overall schema. We look at I tend to think of there being 5 different things that we have in our arrows in the quiver. There's surgery, somatostatin analogs, there'll be lanreotide, octreotide, liver therapy, liver embolization for people who have liver problems only, PRRT, and then various forms of chemotherapy, drug therapy. And I think the other in our center, or in one of the number of centers of excellence around the country, the other thing that will be talked about and that should be talked about is whether there are opportunities that are not yet FDA approved that would really benefit a person. So again, depending on when a person comes to us in their course, maybe that they've had PRRT already with the Lutathera PRRT, and they've been on some chemotherapy, but there's some new forms of tablet therapy that are in clinical trials. There are new and very exciting, I think, forms of PRRT that are in clinical trials. That all of these things should be discussed when we have to make a decision of, okay, what's up first, or what's up next, or who's on base next.
Awesome. All right, so we're going to get into these text questions. First one I have. This might be very specific, but if you can't answer an exact answer, we'll kind of tweak it a bit. So who is the best expert for a NET tumor next to the urethra in Los Angeles? Or if you don't know anybody specifically, what would be your course of action to find that best specialist?
I would talk with Marianne Wayman, actually. Or else, so groups like NCAN has just got a great sort of database and sense of who the people are in any given place. Also, there are, for somebody in Los Angeles, there's also the LACNets. California has 2 great patient groups, NorCal Net, and LACNets, and again, those folks would have their ear close to the ground. I know some of the, again, the specifics of this particular one. I'm not sure whether we're talking about an abdominal surgeon, and there's Dr. Ganji down there.
Yeah.
So there are people at UCLA and perhaps at Cedars, but they're not coming to my mind apart from Dr. Ganji. But the specifics of the question raised the question in my mind as to whether we're looking at something that's urological or more surgical oncology general.
Right.
But
Okay.
those places would give some information.
Great.
I got another one here. My husband has a non-functioning functioning PNET. His chromogranin has always been negative, and it was negative on his pathology from the surgery. Does this mean the tumor is less virulent since it has always been negative and normal? Can at some point the chromogranin turn positive, or is tumor become functional?
So the the level of chromogranin does it's not a very direct monitor of aggressiveness of tumor. So if by aggressiveness of tumor you mean the growth rate of the tumor, in the pathology report, what I would look to first is what they call the grade of the tumor. And the grade of the tumor, you might see it in a pathology report represented on the Ki-67 index. And that refers to how many active cancer cells there are in the tumor at any given time. Aggressive pancreas carcinomas may have all of the tumors, all of the cells in an aggressive carcinoma of the pancreas might be dividing, whereas perhaps 3%, perhaps 5%, perhaps more or less in a pancreas tumor. So I would look at the chromogranin doesn't really tell me much about aggressiveness. It is quite possible that blood chromogranin levels will increase over time with growth of tumor and be a marker of growth of tumor. However, chromogranin is many of the tumor blood markers. You have to interpret them in the context of other medical conditions, of other medications. With chromogranin, the particular medication is the group of medications called PPI for short, or omeprazole, Prevacid, Nexium, that sort of acid-lowering medication will falsely put up chromogranin. So, as to the other component of your question, could a tumor that's non-functional become functional? Yes, it can. So we have certainly had a minority, but a group of patients whose tumors have not been causing symptoms of say diarrhea or sugar abnormalities or other functional symptoms, which then over time become that way and change.
I have another question here. Do you usually start Afinitor at 10 milligrams, or do you ease in with a smaller dose?
So this goes back to my role in a multi-specialty clinic. I'm a medical endocrinologist by training, so anything to do with somatostatin, octreotide, which is synthetic somatostatin receptors. I've been trained in all of that. Afinitor and capecitabine temozolomide, these are either chemotherapeutic agents or what are called tumor-directed therapies, and my medical oncology colleague is the appropriate person who oversees that. So. But knowing my medical oncology colleague, she will take into account whether she thinks that the side effects of Afinitor will be particularly problematic because the person has other medical conditions and may start at 5 milligrams, otherwise starts at 10 milligrams. So it's again a very much a tailored approach, and it's a tailored approach based on what other health aspects have occurred in any given patient. Sorry to hedge on that one, but there you
go. Actually, I do have a follow-up from the same person. What do you consider between PRRT or Afinitor for second-line protocol when it's spread to the bone after somatostatin analogs?
So, PRRT, if you compare the the duration of response of PRRT versus Afinitor, and the overall response with PRRT and Afinitor, PRRT wins out in that battle. And thus in my practice, in our practice, and it also, in my opinion, certainly wins out in terms of the relative side effects that that those two approaches may have. That being said, there are, again, in very specific circumstances, there may be situations where we would prefer to hold off on PRRT, and that Afinitor, for example, would allow us a bridging time, so that we could get PRRT when we wanted to get PRRT. Now, what I mean by that, or one example of that, is that I'm particularly excited about some of the newer forms of PRRT, the alpha particle PRRT that's becoming more widely available in clinical trials now. And again, depending on the specifics of any given individual, there should be a conversation about whether a person would be better off holding out until they can get into an alpha particle PRRT clinical trial versus going forth with the FDA approved Lutathera that's available at the moment. Again, a conversation that needs to be had. So in my experience, in that situation, more people in our clinic will go to PRRT than will go to Afinitor. It may be slightly different in other clinics, depending on the experience of the providers. But there are areas where you have to consider something like Afinitor or capecitabine temozolomide as an agent that might put you in a better place strategically down the road, with different therapies. So it's that's what I would say to that.
All right. Can you discuss rising fatigue? My surgery was 2 years ago, and I'm not on chemo.
Surgery was 2 years ago, not on chemo. I think a lot of individual things there. First of all, do not forget that many people can have issues with fatigue and not have cancers at all, and those issues of fatigue may be related to sleep problems, sleep apnea, other medical conditions. Those have to be thought about before we get sort of tunnel vision on the cancer related fatigue. Another important aspect that has to be considered in fatigue is whether there's significant depression issues. How are you dealing with the psychological burden of having gone through a cancer surgery? So those are areas which are perhaps related in some way to the cancer, but can be issues with anybody who doesn't have cancer. Coming back to the more neuroendocrine tumor related issues. So again, I'd have to sort of probe a little deeper. Had surgery, but do we know if the cancer is there any evidence of cancer in the body? growing cancers can cause growing fatigue. That is certainly one thing. Do we know if you're on monthly injections, lanreotide, octreotide? Both of those agents can actually reduce your thyroid hormone and reduce it in a very subtle manner, such that many practitioners wouldn't consider that a person has hypothyroid or underactive thyroid, because the numbers don't look like the typical underactive thyroid. So there may be some very specific patient related issues. Another common one that is overlooked, many carcinoid tumors are in the small bowel. So you have a portion of your small bowel removed. So your small bowel, particularly the last part of your small bowel, is where you absorb your vitamin B12. And people can get either vitamin B12 deficiency or anemia, or by virtue of removing the small bowel where you absorb your nutrients, you may have a nutritional issue related to that. So not specifically to a regrowth of the cancer, but a side effect of the surgical procedure that you've had. So again, a lot to think about, a lot to unpack with your physician and think through.
Absolutely.
I just want to make a comment about that. As a small bowel resection, it took about 6 months to a year before my B12 crashed. I am on monthly B12 shots. One thing that people should know is that you can't absorb the B12. You cannot take B12 vitamins because your body will not absorb it. So you need to make sure that you check with the doctor to see if you need B12 shots, or to take it sublingual where it dissolves underneath your tongue, or there's one that I believe goes up your nose, because I know a lot of patients that say, oh, I'm B12 deficient, and they go to the store and they buy all this stuff and you're not absorbing it, so you're just wasting your money. So make sure that's something that you really should make sure that you talk to your doctor about, because I did not know about it. I found out later on by going to a support group meeting that this is something that could happen, because no doctor ever mentioned it to me. So that's really glad that you brought that up, Dr. Dillon, because it's very true. There's a lot of small intestine patients out there that are B12 deficient.
And if I may just put on one other sort of overlooked aspect of fatigue, specifically related to neuroendocrine tumors. Neuroendocrine tumors produce serotonin. Serotonin can cause heart valve abnormalities. So a person can maybe more and more fatigued because they're actually having overlooked heart valve abnormalities. Carcinoid heart disease. So again, something that needs to be thought about.
Is that something that you recommend an echocardiogram every year or so to a patient?
Yeah, I do recommend an echocardiogram at the baseline, and in patients who have elevated serotonin, I do that annually. I also use a blood test called a BNP, which becomes elevated if the function of the heart becomes less efficient, and so it's a tip off that there may be something going on with a heart valve in people who have normal BNP and their baseline echocardiogram was normal and their serotonin is normal or pretty close to normal. It might be every couple of years for an echocardiogram, but an echocardiogram there should be a routine place for an echocardiogram.
Okay. We have a lot of questions. So next
so I
one
should
we
make
have
short answers.
Yeah. So what is the treatment plan for someone who does not have receptors and the tumor is spreading?
Okay, so not have receptors means that certain treatments are no longer on the table. Monthly octreotide lanreotide or PRRT. which means that again we look at surgery, and a person who has no receptors, the other available treatments become more important to really consider whether they are possible. So surgery needs to be reconsidered. People who have receptor negative tumor in their liver, the forms of liver tumor embolization, including radioactive liver tumor embolization, called yttrium-90, or called Therasphere, or called Sursphere, and then the chemotherapy, tumor-directed therapies, the drug therapies that are not based on the need for somatostatin receptor, and again keeping an eye on clinical research, newer forms of therapy.
Okay. We have someone here who had 40 pounds of weight loss in 6 months on stanostatin, 18 months post-op, new mets on the liver scan. Would lanreotide likely cause massive diarrhea if stanostatin did?
So sandostatin and lanreotide can cause diarrhea by virtue of their effect to decrease pancreas enzymes. That is a reversible cause of diarrhea. I think taking pancreas enzymes would be the appropriate thing to do, whether you're going up on a dose of sandostatin or whether you're changing over to lanreotide. Just make sure that you've been adequately treated with pancreas enzymes, because that's the cause of diarrhea as a general rule with those agents.
What is the prevalence of multiple primary tumors, for example, small bowel and pancreas?
So, I think my colleague Jim Howe wrote a paper on his experience in over 100 patients with small bowel tumors. One patient had 120 small bowel tumors. His average number of small bowel tumors was something between 3 and 10, but multiplicity. So actually, the majority of people, when looked for carefully enough, seem to have additional small tumors within the bowel. There are some people who clearly only have one tumor. Again, it goes back to the importance of having a neuroendocrine tumor surgeon who knows about multiplicity and will carefully screen the whole 15-20 feet of small bowel for this issue. In pancreas, it's less frequent, less prevalent. When I see multiple pancreas neuroendocrine tumors, I'm thinking of a particular genetic condition called multiple endocrine neoplasm, which would merit a genetic testing. So not an uncommon thing in small bowel, somewhat uncommon in pancreas, but maybe genetic.
Okay. Do you recommend Opdivo over PRRT as an alternative?
Opdivo. I don't know. Someone will have to help me out. Opdivo.
I believe it's a new agent, but I don't know how much it really is used in the neuroendocrine community.
Mm-hmm.
Yeah, this neuroendocrine specialist hasn't come across it, and it may be that it's a brand name of something, but but I'm yeah, if anybody wanted to Google it and give me the actual name of the drug, I'd have an opinion. But it's not something that comes up for me in a should we do this or this.
Okay.
I want to understand if there's any relationship between Cushing's, high levels of cortisol continuing to rise when the adrenal gland has been removed, a tumor showing up in the pancreas, can the tumor in the pancreas raise cortisol levels, or maybe the origin maybe from another organ?
Right. So a neuroendocrine tumor of the pancreas. One of the previous callers had talked about functional tumors, that is, tumors that make hormones and chemicals that cause symptoms. In the pancreas, there are many different hormones that can arise. One of the hormones that can arise in a pancreas neuroendocrine tumor, as it can in a lung neuroendocrine tumor, is a hormone called ACTH. And ACTH stimulates the adrenals to produce cortisol. So a person with a pancreas neuroendocrine tumor can have what we call ectopic ACTH syndrome, or Cushing's disease, related to the production of a hormone by the pancreas neuroendocrine tumor. That's easy to figure out, because not only the cortisol is elevated, but also the ACTH level is elevated as well.
This I definitely want to hear your answer on. My oncologist is recommending PRRT. Is there a new version that I may benefit from, or I'm going to kind of add to this? Are there other options of a course of treatment?
Sure. Yeah, I think it's so important to, when you come to a branch point in the road, that is, you're sitting in the physician's room, and the physician is telling you, these tumors are getting bigger, we need to do something different, different from the shot, or different, that you and your physician think about all of the options. PRRT is a very common next step after surgery, lanreotide, when there's progression of tumor there, but it's not the only next option. It is, if tumor is only growing in the liver, and other tumors seem to be stable, then can we either do an ablation of the tumor in the liver, or an embolization of the tumor in the liver? And should we talk about the other clinical trials, and where things are at with clinical trials? So the issue with clinical trials is that they can be difficult to get into. You may need to travel a significant distance, because different hospitals will not have not every clinical trial is run in every hospital. But there is again, I am excited about the prospects for newer forms of PRRT. The alpha particle PRRT. It is a conversation that you need to have with your oncologist. If it's a situation where these tumors are growing, we need to do something, and do something fast, then short of taking a trip to Europe, perhaps to get alpha particle PRRT, if you're not able to get into a clinical trial on a timely basis, then going with Lutathera PRRT is the appropriate choice. But again, there's no sort of blanket answer to that question. All things have to be considered, because no one thing is curative. Therefore, you will be in this room, in this situation, in 3 years' time, or in 5 years' time, facing a group of possibilities again. You do not want to have used up certain important possibilities when you might need that possibility sometime in the future. So again, you have to be able to talk with your oncologist about the next step, but the next step as well.
Right. Never, not usually the first course.
Right.
After 2 years of octreotide and progression, I did 4 rounds of PRRT, peritoneum, mesentery, lymph nodes, and beginning liver disease. Beginning in liver disease. What could be the next treatment after inevitable progression? Can you have alpha PRRT if you had Lutathera?
Right. So again, at the time there is progression, I like to go back to that schema that I have and see if any of depending on where the progression is, what specifically is going on, whether there are any additional options that are on the table. It is entirely plausible and possible to get into an alpha particle PRRT trial after having had Lutathera. Alpha particle PRRT trials that are ongoing in the United States at the moment, there are sort of two types of trials. One is a trial for what are called PRRT naive people, i.e. they've never had PRRT before, and the others are trials for people who've had Lutathera PRRT already. So Lutathera itself is a possibility for a person who's had Lutathera once. We sometimes repeat Lutathera. May not repeat the 4 cycles. It may have to be tailored, but alpha particle PRRT is a possibility there as well, as are chemotherapies, other clinical trials. All things should be considered.
Okay. I want to jump right back into the comment section here on the YouTube. What's the best way to connect with the University of Iowa cancer system? Do most insurance companies allow it in the institution for a second opinion? Does the University of Iowa help with the insurance clearances?
So I'll take the last one first because the answer is a simple yes. It helps with the insurance clearances. The second one is, do most insurance companies cover? If you've been dealing with your neuroendocrine cancer for a while, you've probably had frustrations with your insurance company and what they cover and what they don't cover, and every insurance company is different, and so many companies do cover treatment evaluation at secondary evaluation expert centers. Some insurance companies will say that we cover this expert center and that expert center, but not that expert center. So it really can be quite variable. And then calling up our cancer center and saying that you have a neuroendocrine tumor and then there's a website for our Holden Cancer Center as well that will bring you into the neuroendocrine tumor category, is how people get in touch with us.
Okay. I have one here. What is the percentage of growth that would require someone to come off chemoembolization trial? We were told that the growth was enough to stop the trial. Okay.
The thing about clinical trials, which is different from non-clinical trials, is that everything in the trial is really driven by the criteria of the trial. The trials are very specific in who they will accept for trial, what their kidney function has to be, what their liver function has to be, etc., etc., etc. There's a lot of T crossing and I dotting. The trial it's written down in the trial documentation that you should see if you're signing up for a clinical trial. What exactly will trigger taking a person out of a clinical trial? And that might be 10% change or 20% change in one tumor or 3 tumors or whatever differs for different clinical trials, but that is a number that's in the paperwork of every clinical trial. It has to be, or else the clinical trial is not will not be accepted by the investigation board or the FDA.
Okay. Let's see. How does kidney health? How does the health of a kidney affect treatment decisions?
Very important question, and it's can lead to difficulty in treatment. So, one example. So, doesn't particularly affect surgery. Doesn't particularly affect the lanreotide or octreotide or the Zermello that we mentioned previously. Can affect some of the drug therapies, but not others. I think Afinitor is also used in kidney cancer and has been used in people who have decreased kidney function. An example, however, that I would give would be PRRT. So one of the, I mentioned with PRRT trials that they're very specific about what your kidney function has to be to get into the trial. And the reason is that when a person gets PRRT, radioactive octreotide, injected into their arm, that circulates around their body for the next 3 or 4 hours. Much of it sticks on to tumors where it'll start to kill tumors, but then a person pees out the rest of it. Now, if your kidneys aren't working well enough, you won't clear out the excess radioactivity as quickly as usual. So it will be circulating around your body longer, and particularly exposing your bone marrow to the damaging effects of radioactivity. So people who don't have good enough kidney function can have potential for more damage to their bone marrow, to the red blood cells, white blood cells, platelets. So in those people, the usual one-size-fits-all PRRT dosing, the PRRT dose that is given is 200 millicuries of this Lutathera, and it's given 4 times. In a person who doesn't have appropriate kidney function, that has to be modified, because if you give a full dose 4 times, you will very likely overexpose bone marrow to the toxic effects of radiation. So that particular situation really does require that a person is in a specialty center for neuroendocrine tumors, because many smaller centers now are using PRRT, and PRRT is a very safe treatment and can be used in smaller centers, but this is one of the situations where a person would be much better off in a larger center that can tailor the dose.
Now, in terms of clinical trials, let's say, where's the best place that people can find information about how to get into a clinical trial?
Yeah. So again, there may be good information with groups like NCAN and some of the other groups that we've mentioned already. The repository for all clinical trials in the United States is clinicaltrials.gov. If you go into clinicaltrials.gov and put in carcinoid and make it USA, and there's a drop-down menu for active studies, you'll see all the clinical trials for carcinoid tumors, which is you'll see a lot of clinical trials. It can be sometimes difficult to weed your way through them. I think it can be a helpful starting point in discussion with your doctor, with your oncologist, about clinical trials that is the place where physicians will certainly find which clinical trials are available and which institution they're available in, because as I mentioned, an issue with clinical trials is that the clinical trial that you might like to be in or that might benefit you may be the other side of the country.
I've got two. Oh, go ahead.
Oh, and also nanets.net also has a listing as well. We have a listing, but it's nanets.net and clinicaltrials.gov.
Perfect.
Yes, thanks.
I've got a couple here. I'm trying not to get too case specific, but somebody who's newly diagnosed, liver embolizations and monthly shots were done. The chromogranin A numbers decreased from like a 200,000s to like 300s. Is that a good sign?
It's a good sign that chromogranin has decreased. There are three things that I look at when I see patients coming back to me in clinic after being put on a new medication. One, are they feeling better? Do they have less of those flushing or diarrhea or other symptoms? Two, I look at things like chromogranin and serotonin, other blood markers. Three, perhaps most importantly, I look at scans. I look to make sure that I'm not seeing any growth in tumors, that I'm seeing stability of tumors, because lanreotide and octreotide are not agents which will kill tumors. They are agents which are there to inhibit the growth of tumors and also inhibit the tumor production of hormones and chemicals that cause carcinoid syndrome. So yes, it's a good sign that has gone down, but I take it in the context of those other two as well.
Must one always go on lanreotide to prevent multiple small lung tumors from multiplying further?
So lanreotide and octreotide both have clinical trials that show that they inhibit growth of tumors that have those receptors, the somatostatin receptors. There are some neuroendocrine tumors that grow exceptionally slowly and seem to grow so slowly that from 6 months to 6 months or even year to year, there doesn't appear to be any change in them, despite not even being on octreotide or lanreotide. So a person doesn't. I'm not sure how to answer that question. Again, it's rather specific.
Yeah.
But in general, these agents are helpful in slowing tumors. Some tumors are so slow that you would hardly notice the difference, and it's just and where that person is at in their lifespan, it just doesn't make sense to them to put up with the pain of a monthly shot, the hassle of it, the cost of it, the side effects of it, for a tumor that's growing so slowly anyhow.
All right, we're going to get 3 more questions here. I'm not going to get into too many case-specific things, but let's see. We got. Can you recommend where to find particle PRRT providers, alpha particle PRRT providers in Europe and Italy?
So in Europe, we have sent our patients for alpha particle PRT to a clinic run by Dr. Richard Baum, Baum. He used to be at a clinic in Bad Berka, Germany. He has another clinic now that's again, I'd have to look up the address, but Richard Baum, he's a very well-known PRRT person. He's very well connected with the NorCal network. So we have used Bad Berka, Germany, and Richard Baum for European alpha particle PRT. We previously used areas in Basel, Switzerland, but I'm not sure that they're using alpha particle PRT. There are other areas in Europe. I believe there's Rotterdam has alpha particle PRT.
Okay. Let's see.
I guess if that person wants to email me, I will get an address for them. So Joseph-Dillon, uiowa.edu. I will get specifics.
I will post that.
Whichever.
Well, actually, Dad, would you mind posting that email in the chat here for some of these people? We're gonna cap this off. Any of the specific ones, again, we'll put the email address up. Thank you, Dr. Dillon, for allowing us to do that. And I think this is a great question. Can you speak to the challenges and progress being made training new up and coming net specialists for the future patients?
Yeah. So I think there's been incredible progress on developing new talent, younger talent in terms of physicians. I think the professional group for physicians and nurse practitioners, physicians assistants, is the NANETS group, NANETS, North American Neuroendocrine Tumor Society, and they have focused heavily on trying to bring in a younger crew of physicians, oncologists, surgeons, gastroenterologists, and help with their training and get them hooked into the community of physicians and the community of knowledge and the community of research that is necessary to help people deal with their neuroendocrine tumors. So I've seen more progress in that in the last few years than in a long time, frankly.
Absolutely.
Okay. Dr. Dillon, thank you so much. I know there are more questions rolling in. Maybe we can do another one of these.
Sure.
Our next one we're going to do is February. We're going to have Dr. Aaron Saison. So we'll keep everybody updated with the links and where you can find that and stuff. But Mom, you have some.
I have some
announcements.
Announcements. So, as many of you know, we have 5 regional conferences that will be done in 2023. Our first one will be March 11th in Silver Spring, Maryland, April 15th in Omaha, Nebraska, June 3rd, San Diego, California, September 9th, Cleveland, Ohio, and October 21st will be Miami, Florida. We will be doing these monthly meetings for anybody that would like to join us. Like Michael said, next one is February 11th at noon Eastern Time with Aaron Saison from Stony Brook University in New York. He is a surgeon, so we're looking forward to that. On March 11th, we will not be having our meeting because we will be in Silver Spring, Maryland. So the next one will be April. And that will be Dr. Jason Starr. So we wanted to let you know about that. But then I need some help from the NET community. We are working with some of the pharmaceutical companies to do a carcinoid syndrome advisory panel. And what it would be is an anonymous panel. You would be interviewed with a company, and they will send you questions once in a while to do. You will be paid for it. We need about 50 people. There are certain restrictions. I need you to be a carcinoid syndrome patient confirmed by a doctor. That means no short bowel or dumpling syndrome. You need to have carcinoid syndrome confirmed, and you must be committed to a year of answering these surveys. And I need you to contact me at info@neckcancerawareness.org, and I will get you the contact information to the company that would be doing the interviewing. Any information that you give is not sold or shared with other parties. It's private information. So if you're interested, we're looking for like 50 people. Give me a call at 866-850-9555 or email me at info@neckcancerawareness.org and give me your name, address, your diagnosis, your year of diagnosis, and we'll get you that information as soon as possible. Thank you for joining us. Robert, I'm assuming that you put in the Zoom link for those who would like to do a support meeting. Please click on the Zoom link and jump into the Zoom meeting. I'll be right over there to help you. And again, Dr. Dillon, thank you so much for being here, and we'll see you soon. Take care.
Thank you.
Thanks, Dr. Dillon.
Bye. Yeah, thanks. Bye.